Everyone. We will try to start on time. So I'll just have a quick intro and then we get right into it. So my name is Ernst. I work with Médecins, Monde, MDM, and this is a joint initiative from the WHO, UNODC, Harm Reduction International, the European and the International Network of People Who Use Drugs, and MDM. I don't need to explain that currently in all sectors we are facing many challenges to keep our services running, including harm reduction. And luckily in the past days, there's been some great guidance that have come out from different platforms. We have included some of those in the invitation, but I'm sure you're already aware of those. Now, this session is specifically aiming to share practical experiences. So we hope that the interventions will be of inspiration or some useful lessons in there. And we really encourage you in the second part of this session to please share as many experiences from you on the ground in the Q&A session that will be run by Judy Chang and Matt. Before we start in, just a quick note that I think that we're currently really in unprecedented circumstances, but I also like to think that the harm reduction movement is really used to adapt all the time and to face everyday challenges. And as a matter of fact, and other people can speak about this better than me, but I believe that the harm reduction movement has really heavily been shaped by community response to an epidemic back in the days in HIV. So we do have a lot of experience in there, and I hope that this session will help, that we can help each other in sharing experiences to deal with what we're now facing today. So before we get started, a few logistical things. We'll put a poll in the end of this session just to make sure if this is useful and if you would like to see a follow-up of this, and if you potentially would like to see something more specific on one topic. There's a chat function in Zoom. Now, unfortunately, I'm on my phone, so I can't see this, but the other panelists will be able to follow what is out there. And if you would like to bring up something at a later stage, please send your questions to the email that Samantha is going to put in the chat now. So there will be a special email where you can ask any questions for later on. Later, there will be the Q&A session. That's the second part of this webinar, which will be run by Judy and Matt, as I said. So there's a little button and they will explain how to use that later. Lastly, this session is recorded, so you will be able to share it later with other people. So let's get straight into it, as the first speaker is Monica, that will speak about what the UNODC has set up in this time. Up to you, Monica.
Thank you, Ernst, and thank you very much for joining everyone this session. I see that we already have 47 participants, so thank you very much for your interest in this topic. 49 already. So from the beginning of the pandemic, and mostly from the moment that many countries went into lockdown, we received a lot of questions about how to continue to deliver the harm reduction services, how to make sure that they are sustainable, how to make sure that the clients and staff of the services are safe, and also how to make sure that people will receive methadone, there will be enough supplies for methadone or buprenorphine, or there will be enough needles. And of course, I don't need to tell you this, there is a very tough competition for all the medical supplies, and there are gaps in the delivery of many medicines, including methadone and buprenorphine. But we are trying to do our part and make sure that people receive the support that can be provided. So, not to take a lot of your time, I will just share with you presentation on what we did so far, and then I'm ready for questions at the end of this webinar. So as a first response from the first week of the lockdown, we prepared a website. It's on UNODC HIV website, and there you have all the information that we managed to produce so far. Also, to respond to the need for guidance coming from our partners at the country level, but also our colleagues at the country level, we produced very brief, to the point infographics on general information about how to make sure that continuity of the services is ensured, and also looking at the human rights aspects of this, and looking also on ways to avoid discrimination and marginalization of people who use drugs. There are specific information about clients of the harm reduction services, very brief, very to the point. Nobody has time now to read a lot of documents, and also information about service providers. We also prepared information about prisons, and there are infographics addressing the needs of people who live in prison and also people who work in prisons. They are available as of today on our website as well. As you can see, this is information about both guards and medical staff, healthcare staff working in prisons. Of course, we contributed to a number of other joint UN publication on COVID-19 impact on harm reduction services, on services available for people who use drugs, that are also available on our website. Thank you.
All right, thank you. And yeah, just to remind that the link to these pictograms or this information is included in the invitation. So that's it for the introduction. We will jump into sharing experiences immediately. We will start with Matt Southwell talking about what is happening among his peer group. Up to you, Matt.
Thank you very much, Ernst. So I'm going to show you a video which is where I introduce the leaflet that we produced in EuroMPUD, and then my chair, Daphne, goes on to explain how we've used that at a country level. And then some of my peers from Bath, 3 of them, talk to you about some of the challenges that they're facing as people who use drugs on the ground.
When EuroMPUD looked at this situation, we realised that the gap in the response was the taking this information and passing it on to active drug users on the ground. So we came up with this set of guidelines that was produced as a simple photocopyable resource, which could be easily and cheaply replicated around Europe and in fact now around the world. So this has now been translated into 20 different languages and pushed out by our drug using groups in different countries to reach drug users on the ground.
We tried very hard to make it very easy to be used by local networks. One of those networks that really can show us how it worked is the PEERNAPS, the Greek network, because in Greece is very tough. Here we see Christos in the streets of Athens. Greece has very tough quarantine. And this means that the streets are empty, there are no shops, there's no restaurants, there's nobody in the streets, but there is a whole community of people who go to the center to score, people who are considered, there are some people who are immigrants and they are homeless, but there are many people who are considered ruthless.
Yeah, at the moment, chemists aren't letting drug users go to the chemist to even pick up and do needle exchange and stuff. They won't even let us in the building. They're treating us like second-class citizens, and it is so hard. Even the services that we get our scripts from, the ones that normally do the needle exchange and that, they're closed. It's impossible, and it's putting us more at risk than ever. And I've been using for 15 years.
Hi, my name's Stephanie. I'm a drug service user in Bath. And the last 7 days, I've only had methadone for 3 because although they were supposed to be delivering to me as I'm vulnerable and I've had COPD, they've only come round twice. I'd really appreciate it if you could think about maybe doing a weekly delivery for people in a vulnerable situation, because I don't want to go, I don't want to make myself ill or worse. I'm a granny as well, so.
So that's the voices of drug users from Bath. There were other drug users who also wanted to talk, but life is quite chaotic at the moment, with people really struggling to find drugs and struggling to interact, which made videoing with other peers who wanted to share their messages with you more difficult. But the key messages are, you really need to think about how to get needles and syringes out there. There are other epidemics going on as well as COVID-19 that we need to keep on responding to. We need to recognise that people are at home with take-home doses, and if they're not, we need to be advocating for them to get take-home doses of OST. And we need to make sure that people also have access to naloxone through this time. So we're working with the peers that you saw to make sure that they get access to needles and syringes, and we're helping deliver methadone to our peers who are locked down. I would encourage you to think ahead in the same way in your country context. So thank you.
All right, Matt, thank you very much. Very powerful intervention. And maybe later on in the question and answers, we can talk about what you were mentioning at last, how your peer group is now helping to get the OST and the NSP ongoing. Okay, that will bring us to the next session. That will be Judy Chang from the International Network of People Who Use Drugs. She will talk about the advocacy efforts, and then she will show a video from India, I believe. Up to you, Judy.
Thanks, Ernst. I'll just pull up my slides. Okay, so I'm the Executive Director of the International Network of People Who Use Drugs. We're the global peak body representing people who use drugs. So we know that COVID-19 does not discriminate, but it does exacerbate existing political and social inequalities. So people who use drugs are at increased risk of overdose, especially with potential changes to the drug supply, and also because COVID-19 puts additional pressure on the respiratory system. The increased police presence on the streets also makes it more difficult for people who use drugs to be moving around at this time. So what we've seen with COVID-19, that it really does expose the flaws of many opiate substitution therapy programs, because many of these rules and regulations have always been focused more on social control and punishment. So specifically the rules and regulations that now do increase the risk of COVID-19 transmission for people who use drugs is that in many countries and programs, they have no take-home policies, or they are inconsistently applied where they do exist, or they're only available to so-called stable clients. Many programs also require supervised and daily supervised consumption and compulsory face-to-face counselling. There's also compulsory urine testing in many programs where a positive test leads to expelling people from the programs. And there's also lengthy and arbitrary entry procedures. And this is obviously more dangerous because we're at a time where there's going to be an increased demand for OST. So as peer advocates, what we've always done is that we've acted to make sure that people who use drugs have trusted and clear information about how to protect themselves. And we advocate for programs and policymakers to take action to make sure that people who use drugs have the resources to be able to do this. So in early March, Russell Newcomb and Cheryl White from 3D Research, they're longstanding members of Input. They shared and disseminated practical advice on how people who use drugs can protect themselves. So some of the advice includes not to share drug using equipment, the need to stock up on drugs and also drug using equipment, and also if you are experiencing symptoms, to make sure that you're staying at home, not visiting your harm reduction center at that time, and general information on hygiene. So we know that if people who use drugs, if they to be able to follow this advice, we actually do need changes within the system. Otherwise, it's not practical for people to be able to follow the advice. So we did work with input, and we'll continue to work with UNODC, WHO, and the Global Fund to make sure that the advice of people who use drugs can be integrated into the systems of harm reduction programming. So some of the key messages that really stood out for us is the urgent need for take-home doses, and also for service providers to provide practical advice for people on how to manage the takeaway doses if they're not accustomed to getting long takeaway doses. We need low threshold programs, including entry procedures. There needs to be distribution of extra supplies and equipment, including naloxone and disposal bins, and that outreach workers and harm reduction staff need safety gear, hygiene protocols, and also permits to be moving around. There needs to be a ban on expulsions from harm reduction services, and of course adequate funding and supply management. So with these changes, I mean, we've always needed these changes before COVID, because we've always needed humane and appropriate healthcare. The arrival of COVID has just made these much more urgent, since the way harm reduction services are structured make it impossible for people who use drugs to follow COVID-19 guidance. So there is going to be a lot more that we need from the international community that goes beyond harm reduction and health. But we're going to, need to be seeing structural changes, and we are releasing a global civil society letter on Tuesday with a list of recommendations. So just finally, we know that peers and community are resilient. As Matt mentioned before, we've had to deal with crises and also crises that are ongoing: HIV, hepatitis C, overdose, but with the arrival of COVID and the advocacy around it, we have shown that the community, can operate and does operate to look after itself, often before the government. There is an urgent need to reform the harm reduction system, and we're going to need decision makers and programmers to take note of this, because without the changes to harm reduction programming, we're really being set up to fail in the face of this crisis. So the next section, I wanted to share a video from a colleague in India. So one of the things that really has stood out for us is the need for take-home doses as country after country are going through lockdown. So I'll just share the video. Oh.
Hi, my name is Charan. I'm from India. I am working with the Alliance India and also the member of the Indian Drug User Forum. Just an update on what is happening in India in regard to take-home doses for buprenorphine, which we have been debating. We have been consulting with different experts for over the last 10 years. It's a blessing in disguise now that the take-home doses medication is available now, both for bupe as well as for methadone. For bupe, it is 1 week take-home doses that has been given directives by NACO, and for methadone, it is for 3 to 5 days, depending on the doses. But again, methadone is being implemented by Ministry of Health. It does not come under the NACO program, so they have different guidelines. But nevertheless, it's a big relief for many people who are on both bupe as well as on methadone. So with the evidence of what we have generated, we are also helping supporting Nepal as well as Bangladesh. Nepal, as you are aware, that they have also initiated their take-home medication and it's been implemented. Bangladesh, we are still working with them, trying to help with them on what could be the right step for Bangladesh to take ahead with the take-home doses for buprenorphine. The directive from NACO came on the 23rd of March for all over the for all over the country. We have about 225 OST centers and about providing buprenorphine, and about 15 or 16 methadone center supported by the Ministry of Health. So, but besides that, there are still some challenges. So some of the challenges that I wanted to list down quickly is that there are some states, in spite of the NACO's directive, they have not yet started implementing the OST take-home medication. I don't know the reason why they haven't done it, but we have also taken up steps from our side by writing letters to NACO, and I'm happy to also tell you that in one of the sites where the problem was highlighted, was identified, that particular site, they have also started dispensing OST medication. But the challenge is that they are people who are below 2 milligrams, they are not being provided medication, take-home doses, by the doctors, saying that they have to be on tramadol, which has been prescribed by the doctor, and they have to buy it for themselves from pharmacy, which is not at all acceptable for us, because we have the right to access to medication, which is being provided by the government, and no matter whether we are on 0.4 milligram or 0.8, we should have access to that medication. And this is the fight that we will still continue to fight, as well as advocate with the particular center, as well as with the National AIDS Control Organization. The other issue is about no new enrollment for drug users on the buprenorphine. But then we have done some very quick calculation, and we would be going with the calculation to the respective state AIDS control society, saying that, you know, this is the amount of medicine that you have, and you know, you can enroll new people on your program. So we are supporting the states. We are supporting the State Drug User Forum to write letters, so that it is implemented effectively wherever it is required. And I also firmly believe and follow Dalai Lama's wisdom and some of his writings. So what I'm following at the moment, and what I'm also telling other people, is that this is one of his quote, saying that know the rule well, so that you can break them effectively. So we will study the rule properly so that we can break them effectively, to ensure that people who have the right to access to medication have access to OST take-home doses, and this continues even after the corona pandemic. And I wish that this is also being followed in other countries, and we also see a better world with better access to medication for all our friends, for all our peers, for all our brothers who are in need of harm reduction services, and particularly buprenorphine as well as methadone take-home doses. Thank you. Hi, my name is...
So sorry, I just want to clarify, when Sharon mentions NACO, it's National AIDS Control Authority.
All right. Good. Thank you very much, Judy. And in the recorded version, we will have another intervention that we will integrate from Nepal, but for the sake of time, and we want to keep as much space as possible for the question and answers, we will now first move to Annette Verster, who will talk about the situation in Morocco. Up to you, Annette.
Annette, you're muted.
I'm sorry, I was muted. Good morning and afternoon, everybody. I'm Annette Verster from the World Health Organization, and I would like to thank the organizers, including especially Médecins du Monde, Harm Reduction International, Input and Euro Input, together with UNODC and ourselves, for organizing these webinars. And I would like to shows two videos from Morocco, and Morocco is a country and I think it's a good example of how collaboration between the Ministry of Health, the doctors who are running the clinics to provide OST and NSP, and the community are working in trying to continue these life-saving services while protecting everybody, both the clients and the staff. So we have two videos. They're in French and in Arabic, and they are subtitled in English. And just to maybe quickly summarize the key points of this, to explain the key points of these, of the structure in Morocco. Let me share my slides. So here's a very quick summary of what the two videos will show. You can see here that there's around 2,000 people on opioid substitution therapy in Morocco, and that includes people in prisons and around 20 homeless people. And that for the last few weeks, they have been able to provide take-home dosages for 2 weeks as a minimum for people who are stable on methadone, and that is the majority of them. And then for people who are still not completely stable, the frequency is a little bit more, a little bit higher. So in order to get the methadone, people have to sign a contract, and in addition to the actual medication, there's also additional psychosocial support, but that is going through through YouTube or phone or WhatsApp, etc. They're also working on getting people who are on the wait list to start an OST as well. I think they're also working on continuing NSP and also providing naloxone. But to just show you quickly that the government developed guidance on this continuation of harm reduction program in the country. And for the staff, there's another range of issues that they work through virtually as well, through WhatsApp and Zoom meetings. And they have, luckily, they are in the possession of enough equipment for PPE, personal preventive equipment, and methadone stock for the rest of the year. And the interesting part, I think, and I hope that will be clear also from the videos, is that there are currently OST clinics in 7 cities, but that they are providing people who, because the country is in lockdown, so people who cannot come to these cities who live elsewhere, they are providing them methadone take home through peer outreach workers who bring the methadone to them. So the ministry has developed special documents so that people can carry the methadone as well as go out of their cities in order to continue the treatment for people. So this is I think it's a really good example of collaboration between the various levels, and I will leave you there to see the two videos. Thank you.
I think there is sound with it.
Sound. Yeah. Maybe in the meantime, I just want to acknowledge Dr. Boutaina Elomari from the Ministry of Health and Dr. Fatima Sergini, who have organized these two videos and made them. Thank you. And Dr. Fatima Sergini is also on the call, so if you have any specific questions for her, you can do that. Can we see?
Yeah, that is great. Maybe later on in the question and answer session, if they just raise their hand, we can give them we can open their mic. I don't know who is setting up the video. Maybe if in worst case scenario, if there's no sound, it is okay because there's also subtitles explaining what's happening.
Yeah.
But
there was some nice music, but we have to
I
imagine that. Okay.
Are you setting it up? No. Okay, great. It's Harm Reduction International. Great.
وكذلك إعطاء الرسائل الإرشادية الضرورية لمستخدمي المخدرات. قمنا بضمان الاتصال الهاتفي مع متعاطي المخدرات وعائلاتهم من أجل تزويدهم بمجموعة من المعلومات ذات العلاقة، وكذلك إعطائهم المستجدات حول التنظيم الجديد والإجراءات الجديدة المتخذة داخل مراكز علاج الإدمان. قمنا كذلك بالتجند كفريق عمل إلى جانب الفريق الطبي من أجل تنظيم مسألة الحصول على العلاج البديل لمجموع مستخدمي المخدرات، خاصة بعد اتخاذ إجراء إعطاء الجرعات لمدة 15 يوما، حيث أن فريق الجمعية قام بالمساعدة في التنظيم وفي الاستقبال وتوزيع الأرقام تفاديا للاكتظاظ وتجنب المشاحنات أمام الباب. بمساعدة ولاية مدينة طنجة تمكنا نحصلوا على 100 وجبة سريعة كنوزعوها حاليا على مستخدمي المخدرات في الشارع من أجل التقليص من الإمكانيات ديال التحرك ديالهم، وعلى الأقل كنوفروا لهم واحد الوجبة يومية مضمونة. بطبيعة الحال من بعض الحظر ومنع الانتقال ما بين المدن، كان هناك مجموعة ديال المتعاطي المخدرات اللي ما تمكنوش انهم يولجوا مراكز علاج الادمان، بالتالي جمعية حسنة تجندت الى جانب الفرق الطبية من اجل الانتقال الى عين المكان واعطاء هذه الفئة جرعاتهم من الدواء، خاصة بالنسبة لمدن القصر الكبير والقصر الصغير وباقي المدن المجاورة لمدينة طنجة. بتاتي الله يرضى عليكم التزموا بالتعليمات وبقوا في البيوت ديالكم رجاء. سويثما ايثما كيف كيدو درين لكم.
Okay, well, while we're setting up the other video, I just wanted to say again that I see that someone from Morocco is present in the audience. So in the question and answers, Fatima, you can click on raise your hand, and then we could give the voice to you. Just maybe we move to the other video. It's a 2-minute video, and then we move into the question and answer session. So Fatima, during that time, if you click on raise your hand, if you click on the button raise your hands, we can give you the floor to you. Okay, just another 2-minute video. And
Suite à la visite de suivi et d'appui du centre d'addictologie de Tanger par l'équipe du ministère de la Santé et du Fonds mondial pour l'amélioration du programme de traitement de substitution aux opioïdes, un groupe WhatsApp a été créé pour faciliter la communication, la coordination et le partage des informations entre les différents intervenants. Ce groupe WhatsApp nous a permis de mieux gérer la situation déclenchée par le Covid-19. Nous avons réalisé la sensibilisation des équipes médicales et associatives concernant le Covid-19 et les moyens de protection, la mise en place d'un bureau d'accueil pour le recueil des coordonnées des patients, la dotation des centres par les flacons sécurisés et les moyens de protection, la mise en place d'un circuit pour faciliter la circulation des patients au sein du centre. Dès la déclaration de confinement, toute l'équipe a été mobilisée pour doter l'ensemble des patients par 15 doses de méthadone, de telle sorte à les répartir par des petits groupes chaque jour. Chaque patient a été sensibilisé sur le Covid-19, les voies de contamination, les moyens de protection. Il a signé un engagement de telle sorte de mieux gérer ces doses de méthadone. Il a bénéficié d'un certificat médical. On a mentionné un rendez-vous. Pour les patients résidant hors de Tanger, une équipe médicale et associative a été mobilisée pour assurer la délivrance au lieu de résidence des intéressés. En concertation avec les responsables des établissements pénitentiaires, les patients incarcérés ont été dotés par 28 doses de méthadone. Dans ce cadre, l'Association marocaine d'addictologie a mis en place des recommandations destinées aux usagers de substances psychoactives, aux professionnels en santé mentale et en addictologie durant la pandémie Covid-19, la création d'une cellule d'écoute au profit des usagers de substances et leurs proches, et l'organisation des conférences online dans le cadre d'addictologie.
Okay, thank you very much, Annette. And so here on, we will move to the question and answer round. And I believe that Fatima from Morocco already raised her hand. So maybe Matt and Judy, you can start with giving the floor to her. I just wanted to remind, during the question and answers, we will launch a poll. It will give you a little box in the middle of your screen just to ask if you are interested or not in a follow-up. So we will now have about 15-20. We have 20 minutes for the question and answer. I give the floor to Judy and Matt.
Thanks, Ernst. So yeah, it'd be great to hear from everyone. So Fatima, would you like to start with a question or comment to any of the panelists?
Hello? Hello? Can you hear me?
Yes, thank you.
So it's Dr. Serrini Fatima Zohra. I'm working in the MMT clinic center, methadone maintenance treatment center, and I'm a member of the association Hasnouna, and I'm just here to give more explanation. So it's not a question more than less than an explanation. I'm sorry, I'm not an English native speaker. I speak French, but I'll try to deal with the situation. So I will just to specify because we didn't produce flyers because we noticed that flyers can be taken off risk. Because manipulating papers, it can be a risk. So we prefer to give more sensitization to our clients. We do also some visits at home because some people, for example, the example for this week, for this weekend is woman who gave birth to a child, and she was in the hospital during this weekend, but of course she has no complications, so she's going to go home, and she is a nearly homeless woman. So she lives in a bad situation, and today we are going to to go visit her, to give her advice how to deal with her baby with the COVID-19. So the intervention here, our intervention is not only to give general advice or to give methadone, is more to communicate with our clients or our patients. We have also a problem of the homeless patients, and this specific population is a real problem for us, because even if the government give shuttles to those guys, the problem is the specificity of the homeless is a person who can't be in a fixed or in a they are always trying to go out. So we are trying to contact them even if they still be homeless, and to give them advice to how to deal. Unfortunately, we have not sufficient moyens to, for example, we have no gel hydroalcoholic to give them towards their hand. We don't, so we are trying to deal with the situation in a bad, we don't have sufficient things to face the problem. And we know all that our people have their specificities, hygienic specificities. They're not so people with good hygienic I don't know condition. So that's our problem now. That's the real problem for us. Thank you.
And Fatima, could I just ask you a question from the chat? People are asking what type of PPE, personal protective equipment, are your outreach workers using?
Excuse me, I'm not a native speaker. Please try to be slow. Okay.
Apologies. We have someone on the chat is asking what type of personal protective equipment are your outreach workers wearing?
We are not wearing, that's the problem. We have just masks, as you see in the video. We have just masks and come on, with the gloves. We prefer not, because we prefer wash our hands. And that's a problem, another problem, because the mask really it was offered by the government, and that's a good thing, but not sufficient. But because we know that those masks are only protecting us for hours, and maximally 1 day, or for example 8 hours a day, not every day. And we have a lot of intervenients, as you say, workers in the associations. That's a problem for us. So somebody, for example, I buy my own gel hydroalcoholic because we don't have sufficient, and in the street we can't find every time water to wash our hands. That's the problem with our teams. We don't have protective clothes for those. So we enter in our homes and we quit all we were wearing, and we wash it every day. That's a problem, of course. That's a problem.
Okay, so just maybe one thing to say, we have now got these masks that are being made for us by local people who are part of sewing groups. And we're now giving these out to drug users. So I will share the design if people would like to have access to these.
Thanks, Matt. So I've just got a question as well related to an issue that you brought up as well, Fatima. A question from Michelle Matias Yepes. Sorry if I'm saying that wrong, from Colombia. I would like to know some experiences with harm reduction, COVID, and homelessness.
Do you want to pick up on the homeless issues? I mean, I showed in the video that we showed, you saw the woman talking with the public toilets in the background. In fact, each one of those public toilets has 1 or 2 people living homeless in them at the moment. the police in are starting to put pressure on the homeless to leave the streets and to move into the accommodation. But for many of them, there are real practical problems about keeping mobile phones charged so they can interact with the new system, which doesn't allow people to connect with each other personally. When I gave out needles and syringes to the people last night, they'd been reusing and reusing needles because they can't find their way into the system. So when we have this new physical distancing within the system, we really need to think about how we communicate that to the drug users on the ground, particularly the homeless, so they can find their way into the system.
Can I maybe also jump in quickly on homelessness? Maybe some members of Gaia Paris are also in the audience, but I just wanted to raise that they're putting a lot of pressure currently on the authorities in Paris to use many of the hotels that are currently empty, to use those rooms to host homeless or roofless drug users in Paris. So things are moving forward. This is obviously maybe more of a high income setting solution, but putting pressure around you to use not used spaces in these times is a very good solution, I would say. And secondly, I just heard that in Canada, in Montreal, they are using an old hospital now to start hosting people that live in the street. I just wanted to share those as examples, and maybe it is worth putting pressure on your local authorities to use places that are not used currently.
I also intervene here because there are, of course, this issue varies from country to country. In countries that have a bigger homeless problem and lower capacity to deal with people living on the street, the situation is quite different. For instance, as far as I know about a project in Romania, there was a shelter for homeless people that was working during the winter, but now that shelter was closed because the winter is over and because there were no resources to continue to keep that shelter, and those people now are on the street. And the only way that can be reached is through peers and outreach workers who are going in the areas where they live. But of course, all the recommendations that we are issuing with washing your hands and keep the safe distance and everything else is very hard to follow because there is no water and soap for people who live on the street. So what we are issuing is recommendation for the governments to take this into consideration, and even if the resources are very limited, to find ways to protect people who are living on the streets as well.
Thank you. So I've just got a clarification from Lucia O'Connell about the system of outreach, distribution of methadone outreach workers, distributing up to 15 doses. Lucia, I don't know if you wanted to expand more on that question or like who the question was directed to.
Hello, can you hear me?
We can hear you.
Hello everybody, I'm Lucy, I'm from MSF, and actually hello Ernst and Judy, and I think I recognize Matt and Annette. Anyway, yeah, I was asking about because I missed some of the video was mute actually in the beginning, the first video. But so there was something that kind of still stayed in my mind. What was the outreach distribution of methadone like? 15 doses to people out there in the community, and then there was 28 doses for people in prisons. And so then I was thinking, how many per person, or how many persons per outreach worker? Could you clarify that, please?
So this was the video from Morocco.
Yeah, from Morocco. Maybe Fatima can also respond more, but I understood that the clinics procured flasks and that these flasks with 14 or 28 days of methadone were carried by outreach workers to patients who couldn't come to the clinics because either they are in lockdown and in other places and cannot enter the city, or because of these special situations like Fatima already mentioned around people in hospital or delivering babies. So the 28 versus 14 days, I think partly one was with regard to prisons and the other one had to do with how stable people are on, because I think it's important to know that that there was already take-home dosages in Morocco, but it was for a few people, and now this has been scaled up, of course.
Okay. Okay. And ART or TV treatment.
Thanks. So the next question is from Wangari, specifically to Monica. Wangari, did you want to pose your question?
Hello.
Hi.
Yeah, so my question, I'm speaking from Kenya. I work with MDM. We appreciate that there has been calls for decongestion of prisons and people are being released like in Kenya and other countries, but we realize that people who use drugs are missing in this because often the terms are very long. So I was wondering what UNODC is doing to support that the people who use drugs would benefit. Is there any country that they have benefited from the release, and what is being done to ensure they benefit? That's one question. My second question is that in Kenya, we have had police disrupt the effort by CSOs, like we've had cases of burning of the containers of water in the dens. And you know, at this time, you don't want to go from police station to police station because of COVID. And so I was wondering what UNODC is doing to ensure that police don't disrupt services for COVID protection of our people in the ground.
Thank you. With regards to early release from prison, we are recommending that prison authorities will take into consideration early release, but also make sure that this is coupled with adequate quarantine or home isolation measures to make sure that people who are released from prison are safe, their health is protected, but also the protection of their families and friends is also ensured in case they were in the prison. There were cases of COVID. There are examples of countries that already implemented the early release. I guess it's too soon at this point to tell you, what is the result of this early release. We are also recommending because there is the visits in prisons are stopped at the moment, to make sure that people living in prison have continue to have contact with their families through other means like access to telephone calls or Skype calls. With regards to Kenya, actually our colleagues in Kenya acted very quickly, and they purchased gloves and the disinfectant and soap for the service providers in the country. So we are trying as much as we can with our resources to make sure that these commodities are purchased, and of course depending now on the way things are delivered due to the movement limitation, we hope this will be available as soon as possible. With is also, I think it's worth mentioning here that in all the countries it's possible to purchase this personal protection equipment and soap and disinfectants and everything else that is needed for preventing the spread of the virus. Also with the funds from the Global Fund, they agreed to use 5% of the grants for COVID prevention. So it would be good to contact the Global Fund recipients in the country and make sure that this request is placed. With regard to the police and how to make sure that they are not dependent on the delivery of the services, we are contacting the law enforcement authorities in the country and issuing technical guidance for them. We will follow up also with dedicated webinars like this one.
Thanks, Monica. So the next question is just from Marie Massus about food distributions. So Marie. Okay, unless,
Can you hear me?
Yes, we can.
Okay, thank you for this webinar. I was just wondering, in the presentation about Morocco, there were mentioned some food distributions, and I was wondering if you could elaborate on this, how they are organized, especially in contexts like in Tanzania, where I am, where other populations in potential need of food distribution, but who are not drug users, do not have access to it, and how do you deal with this situation? Thank you.
Is that a question any of the panelists can answer?
I think the question is for Fariba. Farida again. My understanding was that there were meals from McDonald's distributed among the homeless people who use drugs. But maybe Fariba can respond to if there is an issue about other people also needing food aid who are not using drugs, and how you deal with that, to answer the question from Marie. Fatima, are you still there?
Yeah, are we bringing Fatima in? She's got her hand up.
Hello? Hello, can you hear me?
Yes, we can hear you.
So finally, I want to to clarify the point about the 15 milligrams of methadone. Please, we are not taking home methadone for people with those doses. We give them the doses they need. They used to use. They used to take.
Fatima, if I can interrupt you, I think the question was around the numbers of days. 15 days.
15 days. That, yeah. We're giving them 15 days. No, but we were discussing about the problem of relapses, yes, and the overdoses. That was a problem for us. Doctors were talking about why not to give them few doses of methadone. And we was discussing about that. That's why I wanted to clarify. But now, for now, we are trying to give them. We give them their whole doses, and we are now discussing about delivering naltrexone to the drug users to avoid the problem of overdoses.
I think you were talking about naloxone.
Naloxone, yeah.
Naloxone.
Yeah. We are trying to give a patient the naloxone, and give also the outreach workers naloxone too, because in Morocco the outreach workers don't have access to the naloxone. That's a problem for us, and in those period of crisis, relapses are more frequent than other times. And we have also the problem of people who are not under MMT or methadone maintenance treatment. That's also a problem, another problem for us. Now about the meals, we had meals from McDonald's. We know that I'm sorry, it's not. I'm not doing publicity, but it was the only restaurant who gave us those meals. We know that it isn't the good one for health for our patients, of course, but we say that it's better than nothing, because people don't have sufficient meals to eat. We are in a period of crisis, so for us, and all the restaurants are closed here, and that's why we are giving them. So we distributed for every homeless every day. I don't know if I respond to the demand of the last question. I don't know.
Thank you very much.
Was that how we do it? So we are distributing to homeless in the outreach with the outreach workers.
Thanks so much for your contribution, Fatima. That's great.
Matt, can I just maybe in between, just in respect of time, I do realize we are 1 hour in now. I would suggest for those that have a very busy schedule and have to leave right now, I all thank you very much for joining. I would like to suggest that we maybe take 3-4 more questions, maybe for another 5 to 10 minutes, and then we will make this to a closure for those that have a little bit more time available. Back to Judy and Matt for maybe picking up a few more questions. Thank you.
Yeah, thanks, Ernst. Yes, I just spotted a couple of other questions. Lucia about Lucia Connell, what advice for people that have symptoms of COVID?
Yeah, I think one of the things we're looking at is how we help people who are having to self-isolate, particularly people who are self-isolating for 14 days. So yes, we can get take-home doses to people, but we've got people in our community who are also vulnerable and have suicidal ideation, and managing those coexisting challenges means we may be delivering every other day their methadone to them at home. We also need to think about people's access to just the basics of life. And these are people with houses, people who are at this point not housed. I think the key is to get people quickly onto OST, so then they can access the housing initiatives that are available, and then we can start to give them secure places within which they can self-isolate.
Okay, thanks, Matt. And there was another question from Sylvia. Sylvia, can you hear us? It was about mobile dispensing, but if you'd like to give more detail about the question.
Yeah, thank you. So, Sylvia Yon, Kanko, Kenya. We are exploring the use of mobile vans for the dispensing of the methadone, what we currently have. And there's already a lot of issues around social distancing that we are observing. And also at the same time, the use of DOT is what we have. So as we continue to advise the Ministry of Health towards moving to safer ways of delivering OST, I wanted to get from you the experience there is around mobile dispensing with mobile van, how safe it is, or what are those things that are being done innovatively, besides, of course, the take-home dose that I've already gathered from the experience of India and Nepal. Thank you.
Maybe I can quickly reply with a few words on the mobile distribution of methadone, because I've been working as a nurse on a mobile unit for a few years, a couple of years back. So there are some mobile methadone units around. I think that the first one must have been in Amsterdam, and I've been working on a mobile unit working in Paris. Now, the existing mobile units are often more aiming at direct observation, daily distribution, close to where people use drugs are living. So in the streets in Paris specifically. When you talk about safety, I mean, in order of medically following the prescription of methadone, I don't think there is a big difference between working mobile or from an office. We have doctors on board if need be, and mostly you don't need to see a doctor and it can be distributed immediately on a daily basis. Nothing really changes. I do believe that sometimes people are a bit worried about having methadone in a bus on the street. I am not aware of any situation where that has been a problem in terms of security. So that's just my experience. I think it works really well, and it fits, I think, very nicely in now adapting to whatever current circumstances. Whatever way works now to get treatment to people, I think we should absolutely try and get it out there. So maybe if someone else wants to jump on that.
Maybe just to add that depending on the requirements in the country, I think if, also the people working in the mobile van would need to get the right permit, so they won't be affected by the current restriction. And you know, because police in several countries asking for permit for people who are on the street, so that's, you have to be very careful what are the rules in the country and make sure that you are follow them. And also the personal protection equipment for people working in the van is very necessary.
Thanks, Monica. So we just have a raised hand from Jean-Luc. So sorry if I missed that before.
No problem. Hi, everybody, and thanks for this interesting webinar. I just wanted to check if there are any plans to communicate with institutions in charge of testing existing molecules to treat COVID, and eventually if there are some interactions with the psychoactive substances, how we will communicate that to the networks, and with which institution we should liaise.
Yeah, as far as I know, there's not enough awareness and knowledge about COVID to understand like the interactions with other medications, but I'll let other people speak as well. It seems that, you know, we're trying to play catch up and understand more about COVID.
Yeah, we've had various myths running around the place that methamphetamine can rescue you from COVID-19 or crack cocaine can rescue you from COVID-19. I think we're clear to dispel those myths. It might be a positive thing for drug users if it was true, but we're clear it's not. So yeah, I mean, I think this might be a much longer term issue to know once we start to have vaccines around, whether there's any interactions that might affect our community.
So thanks. So next, Olga Valieva, do you have a comment? I think it looks like, or a question.
You ask me? Hello.
Hi.
Hi, hello. Thank you for your webinar. And I have 3 questions, short. First, about if you have some scientific recommendation about how to move people from methadone to tramadol. This is like this option in Kazakhstan, and people feel it's not so good. And the take-home dosage for Belarus and Kazakhstan is the main issue now for us. And we think about, I understand that all our focal points and people, activists, drug users in country don't have any resource support for working, but they work in it. Each moment they're in front line. And now in Global Fund, in refunding 5% of their grants, but they didn't include in community supporting and how we can, because the advocacy process now is important in each country. That's why we need to think about it also. Thank you.
And maybe just to comment on the tramadol issue, I think we should be very cautious about promoting tramadol as a solution. Talking to a doctor working in Nigeria, he was identifying people overdosing on tramadol with doses as low as 200 milligrams. So if you're looking at the conversion rates, it's a drug that you're going to potentially get into issues of fitting at very low doses. And it's, yeah, so for me, I think we should be looking at ways that we can sustain access to buprenorphine and methadone as the core trusted products. And I don't think, tramadol as a solution should be promoted unless in the most extreme of circumstances, because it has so many challenges that go with it.
Well, with regard to the tramadol question, please, Olga, we can follow on email, follow up on email with more concrete information. But yes, the advice is to support people to continue their methadone or buprenorphine treatment. With regard to the situation in Kazakhstan, we are very much aware about the situation, even if Kazakhstan has a very small number of people who are taking substitution therapy. Currently, there is, due to the movement restrictions, they don't have access to the medication, and we are working now very hard with Annette, I'm not sure if you are involved in this, but we are working with UNAIDS Secretariat to contact the highest authorities in Kazakhstan and make sure that these people continue their treatment. And we hope that the situation will be resolved this week.
Thanks, Olga. Yes, on the question of tramadol, it may be good to discuss more with Charan Sharma, because he did mention it within his video. It seems that the advice doctors are saying if you're under 2 milligrams to move over to tramadol, but the activist there, or Charan, was saying, okay, well, no, we actually need sustained access to OST. But it may be good to speak to him more to find out the specifics around that. With Global Fund programming, yes, I mean, the decision was announced, as other people mentioned, about 5% of program funding can be allocated to COVID, but that has to go through, the CCM, and, that usually takes a long time. So we are trying to explore options as well of perhaps, more rapid ways that can be responsive to community needs. But yes, we agree that I agree that something we need to look at more, how to make funding as flexible as possible.
Just to jump in here, sorry, Monica, just 1 second. Just to the extent that the questions being asked are quite complex, we'll take a list of all the questions that have come up in this webinar and the next one. And to the extent that our panelists or other experts in the sector can give us links or explanations or further resources, we'll be emailing all participants with the extra information.
Okay, I hate to be the one pointing at the time. It must be my Dutch roots. Sticking to what we've organized. So I would suggest that maybe we round this webinar up now with 15 minutes over time. It is difficult to sum up all the really interesting discussions that were going on. I think there was a lot about OST, as we already expected a little bit, that would be a specific area to look into. So what I take away from here is that we really need to look beyond the current frameworks we have existing in country. And I really like to remark that if you know the rule well, you know how to break them. There are a few established models that we know that can be rolled out. So the take-home dose obviously is one. I found it very interesting to hear that in some contexts now take-home dose has been moved into the hands of peers to deliver them. I think that's a really great way forward. We haven't spoken too much about it, but there's also an element of pooling where people are delivered methadone in smaller groups. I think that was coming out of the video from Morocco. The mobile unit, I really believe there is potential in, again, pooling, so making sure that not everyone comes to the same place. The tramadol issue is definitely something that needs further look into, because I really agree with what has been said already. I think it's a very tricky area to blindly shift over to something actually quite radically different. So maybe, as Naomi already said, we can look into the specific questions and see if we can do something more on all of these issues related to OST. I would just move from here to thanking everybody who has been joining this, and of course all the participants, all the questions. And Suchitra, who's behind the scenes, clicking on a lot of things. Thank you so much for running the platform behind the scenes. Can we maybe just get a quick view on how many people replied to the poll that believe that was interesting to have a follow-up? Do we have that information?
Yes, it is. We have about 46 people who voted and 98% said yes.
All right. Okay. Well, then I believe that we have some work to do. Okay. Thank you very much for here. Is there anyone from the panelists that would like to say something? Okay. So that comes with silence. Thank you so much, everyone, for joining this, and see you then potentially in next coming up. Bye-bye.